In this video, we will analyze the optimization of radiation protection practices for patients. This includes a discussion on the modification of exposure factors to reduce patient dose. We will also justify collimation standards for patient protection, and we will review best practices in AEC and grid usage. Lastly, we will give examples of positioning modifications that save on patient dose. The first topic in ensuring radiation safety is to find out who we are performing the procedure on. This includes verifying the patient using two patient identifiers, and if it is a female of childbearing age, we need to ensure that she is not pregnant. The safest time for a female to be imaged is within the first 10 days of her menstrual cycle. After this point, she may become pregnant, but may not be aware. Most pregnancy tests do not confirm pregnancy until a period has been missed, but that doesn't mean that fertilization has not taken place. For liability reasons, many facilities have patients fill out a form so no miscommunication or misunderstandings occur. As you are aware, a growing fetus is more sensitive to radiation than an adult, and screening female patients that could be pregnant is essential to ensuring everyone is safe. Best practices in imaging requires optimization. There are a number of aspects of an exam that can be optimized. Optimization is using the resources you have to make the best decision or situation. That is a huge part of our job as technologists. It's all about balance. The first area of optimization that I want to review is to ensure that the exam is appropriate by weighing the risk versus benefit. Every procedure has some inherent risk. Getting an IV, for example, has a small amount of risk, so small that it is often thought of as a procedure without risk, but hematoma, air embolism, phlebitis, etc. are all possibilities when an IV is started. Now, the burden of weighing the risk versus benefit for any procedure mostly falls on the ordering practitioner and the radiologist. However, the technologist may notice ordering mistakes and unintentional duplicate exams. These types of errors should be brought to the ordering practitioner's attention for correction prior to beginning the exam. At times, we may personally not agree with an exam order, believing that another exam may be a better option with less dose. This is not our call as technologists and is outside of our scope of practice. The radiologist can make such calls and recommend alternate exams. Another aspect of optimization is to ensure quality throughout the procedure to reduce and hopefully avoid repeat exposures. Double-checking for potential artifacts, proper positioning, accurate centering, and other exam parameters prior to taking the exposure, engaging fluoroscopy, or starting the scan can avoid repeats. Good communication and immobilization devices such as sponges, sandbags, etc. can also help to eliminate repeat exposures in scans. By repeating a scan or exposure, the patient's dose is doubled for that particular scan or exposure. This can be a difficult task for some technologists, as we are asked to work harder and faster because of staffing issues. Balancing the quantity versus the quality is not an easy task. Nevertheless, high volumes are never an excuse for submitting non-diagnostic images. Another way that the exam can be optimized is through technical factors. I will spend some time discussing this aspect of optimization because it is extremely effective in reducing patient and personnel exposures, and also because it is within our scope of practice to address. We know that the quality of an image is higher with higher exposure factors. Higher exposures often produce the best image quality, but is this what is best for the patient? Again, it's all about balance. A small amount of quantum model is acceptable. The standard of how much quantum model is allowable should be set by the interpreting radiologist or group of radiologists. In other words, you should be getting input from the radiologist on this question. Without some guidance, it is likely that the department is consistently overexposing patients by 10 to 40%. Balancing dose rate in fluoroscopy procedures is another area that can result in a reduction in exposure. Less exposure per second results in slightly less crisp images, but may be enough for the surgeon or radiologist to see what he or she needs for the procedure. For digital radiography, using higher kVp settings and lower MAS is another way to optimize patient dose. The total MAS that is used is directly proportional to the patient's exposure. For example, If the MAS is doubled, the patient's exposure is doubled. When the MAS is halved, the patient's exposure is halved. As review, a 15% increase in kVp is the same as doubling the MAS, and a 15% reduction in the kVp is the same as cutting the MAS in half. So if we increase the kVp by 15% and cut the MAS in half, the same overall exposure is maintained. With digital radiography, this does not affect the contrast of the displayed image unless the kVp is grossly modified. What this essentially means is that technologists can manipulate the exposure factors to reduce patient dose and maintain the same image quality. To give this a little more meaning, let's look at an example. An abdomen X-ray was performed at 68 kVp and 40 MAS. We can increase the kVp by 15% and decrease the MAS by half. The new exposure factors would be 78 kVp at 20 MAS. This modified technique would result in about half of the ESE, or entrance skin exposure, and maintain the same image quality. We could take this a step further and further increase the kVp by another 15% to 90 kVp and cut the MAS again to 10 MAS. The new exposure at 90 kVp and 10 MAS is roughly 1/4 of the exposure to the radiosensitive small intestines, gonads, and bone marrow of the pelvis. This small step, without any effect on the image quality, reduces the patient's dose significantly. This is an easy way to follow ELARA and do right by our patients. Technologists should strive to use higher kVp settings and lower the MAS on all possible exposures, and constantly monitor their exposure indicator readout to ensure that the exposure factors used are consistently on the lower aspect of the acceptable range. With digital imaging came dose creep. Dose creep is the result of digital imaging systems being able to compensate for overexposed images so well, sometimes up to 20 times the necessary exposure. Underexposed images begin to show quantum model or a grainy appearance that cannot be compensated for by digital imaging systems. When quantum model is enough to make the image non-diagnostic, it must be repeated. To avoid quantum model and needing to repeat an image, technologists began to use higher and higher exposure factors. The images still looked great, but patient doses were on the rise. Technologists need to be aware of dose creep and consistently strive to use the least amount of radiation to create a diagnostic image. This is accomplished through monitoring the exposure factors and exposure indicators and making adjustments as necessary, but always striving to use the least amount of radiation to create a quality image. Automatic Exposure Control, or AEC, was created to standardize exposures and reduce patient dose. And for the most part, it does just that. However, AEC is not a replacement for setting manual techniques. AEC should not be used on certain body parts, pediatric patients, and parts containing metal prosthesis. All of these examples could lead to overexposure and potential repeat exposures. AEC is effective when the proper kVp is utilized, the proper MA setting selected, and an appropriate backup time is set. Accuracy of positioning, collimation, and shielding are all very important when using AEC and can affect the resulting exposure. As always, it is the technologist's responsibility to ensure that the technical factors are appropriate prior to exposure and the resulting exposure indicators are reviewed to ensure chronic overexposures are not taking place. You should know that AEC settings can be out of calibration. As I stated earlier, overexposure is not able to be seen on today's digital radiographs just by looking at the image on the computer screen. You must consistently review the exposure indicators. In addition to manipulating technical factors, technologists can make sure to reduce field size. The less of the body that is exposed, the lower the patient dose. Many times collimation standards are not clearly understood by those working within the department. I often say that today's standards in the imaging department tend to be determined by the loudest technologist. This should not be the case. The interpreting radiologist or group of radiologists should determine the standards, and this includes collimation. Collimation standards, much like technique selection, has become lax at some facilities. Make sure to not assume the radiologist's expectation and take time to find out exactly what your radiologists want as far as collimation so that patients are not having additional tissue irradiated due to a misunderstanding or assumption. Please understand that cropping or masking an image is not the same as collimating the field size prior to exposure. Covering the exposure field with the black surround feature on digital imaging systems is poor practice and has legal implications that we will not go into in this video. It is worth mentioning, though, because consistently masking or cropping the exposure field of images is an undeniable indication that proper collimation is not being utilized. Grids are utilized to reduce scatter radiation, and they are effective in doing so. However, they do increase patient exposure and as a result increase patient dose. It is recommended that grids are utilized only when necessary. What this typically means is that when the part thickness is greater than 10 to 12 centimeters. Chest imaging can be performed without a grid due to the thorax mostly being filled with air, which creates very little scatter radiation. However, a larger body habitus would benefit from grid application on chest as well. This is again a conversation that should be had with a radiologist to verify what criteria would constitute using a grid. Pediatric exposures should not typically be performed using a grid in order to reduce dose to the patient. Patient position is another effective way to reduce patient dose to certain organs. For example, scoliosis exams are often repeated on patients throughout the adolescent years and sometimes into young adulthood. By placing the patient so the central ray is entering the posterior aspect of the patient, this reduces dose to radiosensitive organs such as breast tissue for females and the testes for males. Remember that about 1% of the X-ray beam penetrates through the body to create the image. This means that by placing the patient in a posterior position, the anterior structures are receiving 80 to 99% less dose. This is also true for thyroid and eyes, both of which are anteriorly placed radiosensitive organs. Shielding should be utilized for every exam with few exceptions. The first exception is if the shielding would interfere with the quality of the exam. Shielding practices are often only utilized for the radiosensitive gonads, but there are other organs that are radiosensitive and benefit from the protection of lead shielding. This includes the thyroid, breast tissue, small intestines, and long bones in children. This is especially helpful when the field of view is within 2 inches of the radiosensitive organs. Adjust shielding so it is within 1/2 inch of the light field to cover as much of the tissue as possible, but never place the lead shield in the field of view. This can be very detrimental when automatic exposure control is used. When using a rolling shield, adjust it so that it is as close to the light field as possible and ensure it is placed close to the patient. Remember, the 2 inches that are closest to the field of view are receiving the most dose. Shielding isn't effective unless it is being used properly. You should work to establish good shielding habits, and one way to do that is to try to shield everyone, including the elderly. Some will argue that older patients are not reproducing, and while this is likely true, as we age we become more sensitive to radiation. Therefore, it's important to shield those over 40 as they become increasingly more sensitive to radiation. One could argue that at the age of 90, the late effects of radiation would not have the chance to take effect due to the life expectancy of that patient and the latency period of the radiation effects. And again, while this is true, foregoing shielding on select patients disrupts good habits. The only reason shielding should be excluded is when it would interfere with the quality of the images. However, there are times when shielding should be avoided, such as when a critical exam is underway and shielding would delay the exam when moments matter to the survival of the patient. In situations like this, shielding is the least of that patient's worries. And lastly, use good judgment about shielding. You wouldn't place a shield over someone's head or shield extensively to cause the patient or the family members alarm. Be reasonable and use good judgment. The last topic I want to talk about in this video involves bystanders and family members. When performing mobile studies, it is the job of the technologist to ensure the area is safe prior to taking any exposures. This requires notification of all personnel by speaking to those taking care of the patient and the desk personnel so they can alert anyone heading towards the room. I try to do this prior to going to the patient's room. Once at the patient's room, I knock, enter the room, introduce myself, and ask everyone in the room to please step outside. I always encourage family members to take a break, such as visiting the cafeteria or going to the family waiting room, etc. I also let them know the expected exam time. Once I am finished with the exam, I let those in the area know that I am finished. For pediatric exams, it is best that only essential persons be in the room while the exposure is being taken. For infants or toddlers that require a person in the room, it is best for only one family member to stay in the room with the patient. If anyone does stay in the room, they must also be shielded with an apron, and females of childbearing age must be screened for pregnancy. Sometimes circumstances require more than one person to help, but in my experience, that has rarely been required. Devices that can immobilize the patient without having anyone in the room make sense based on a radiation safety standpoint. Devices such as pigostats immobilize the patient better than humans can and make it so the parents do not have to be in the room or at least as close to the patient. After a child is old enough to be able to follow directions, the parents can wait just outside the room or, if they insist, can stand in the control area during exposures. In this video, we focused on how to protect patients. In the next video, we will review ways to keep ourselves and other personnel safe during radiographic and other imaging exams that utilize ionizing radiation.